EM board bombs.
What's up, guys? It's EM Board Bombs here. We got a special treat. We are joined here by Blake and Marlena. So, three of us. You got it. So, amongst us, we have multiple letters next to our last name. However, Marlena, I think,
has the most.
50 to 60% of them compared to us. So, we bow down to that. Thank you, Marlena, for humoring us and still willing to partake and be a part of the pod. This is EM Board Bombs. I'm not going to explain what we do because if you don't know by now, I don't know where you've been, but the name kind of implies it. And we do board review, but also just life review for EM life. And we do it in a blue collar way. There are a lot of other fancier EM podcasts that you can listen to if you just want to cut to the pathophys and really get down to the nitty gritty. That's not us. You should probably move on and search for other stuff at that point. But if you know what we do, our brand, and you love it, then continue listening on. Hey, Briggs, Marlena, you guys ready to just like roll and do this question?
Let's do it.
Let's go. 45-year-old male with a past medical history of a hemicolectomy presents to the ED with the chief complaint of sudden colicky mid-abdominal pain associated with non-bilious vomiting. He denies any diarrhea with this. He denies any bloody stools. His last bowel movement was yesterday. He has no flank pain, no hematuria. He's very adamant that his symptoms started after watching the Bills and Kansas City Chiefs game. So you naturally assume that he's a Bills fan. He's actually not. His team, the Chiefs, won, but he started gagging after he saw Jason Kelsey's shirtless, beer-covered body next to his favorite amazing pop star, Taylor Swift. He was terrified for his beloved pop star, Taylor Swift, and he's just very worried that Kelsey's behavior is going to cause Taylor to leave the Kansas City Chiefs, and it freaked her out. You reassure him. You tell him that's likely not what's going on and causing the symptoms. On exam, the patient has normal vital signs. He's actively vomiting, though, as he tries to explain all the drama that he was suffering. He has mid-abdominal tenderness to palpation. You obtain a CT of his abdomen with contrast, and you diagnose him with a small bowel obstruction. Which of the following etiologies are the most likely cause of his small bowel obstruction? Is it A, adhesions, B, Taylor Swift drama, TSD, C, neoplasm, or D, is it a hernia? Hey, before we get into this correct answer, though, Briggs, EM Rapid Bombs, ITE time's coming up. Let's go.
Right. Less than a month. Sign up. Go to our website, emboardbombs.com. Sign up.
It's great. emboardbombs.com. Check out the question bank. We drop high yield board review, but also life review.
Yeah.
And, the questions really range anywhere from like 3 to 5 minutes. Some are on the longer side, like 6 minutes. Oh my, 6 minutes. But they're packed with high yield board review. They're juicy, right? And it's $150 a year. You basically get multiple podcasts delivered throughout the week, throughout the month. And you get emails as well delivered to you multiple times a week, courtesy of Marlena and the team. Thank you. Yes, I love the heart sign there. Thank you if you're watching us on the YouTubes. Hey, what's the correct answer here, Marlene?
Yeah, the correct answer for the most likely cause of this guy's obstruction is not TSD. It's A, adhesions.
Boom.
Not to be confused with STD. TSD is a very different pathology.
I mean, they might be related.
Hey, don't associate Taylor Swift with that, okay? All right, guys.
Wasn't implying anything. Hey, we got to give a shout out to our only sponsor, the only one we want, EM News, Emergency Medicine News.
Yep.
Check out their articles online. You can go to the website. You can also become a free subscriber, get something print in the mail as well, too. As long as you're practicing emergency medicine, you are eligible to any free subscription to EM News. So check it out.
Boom. Love it. Hey, your voice is fine, Briggs. Last time I lost my voice, And this time, Dr. Briggs is getting over a cold. And so he sounded like a squeaky mouse a few days ago, but his voice has improved substantially.
Yes.
Yeah,
I
I'm
made
a
the
little
mistake
sad.
of going for a run outside in the cold when it snowed in East Tennessee.
Yeah.
Ugh.
Shut down the city.
Well, some of us, like Marlene and myself, have stronger, vocal cords, but that's fine. That's neither here nor there.
Yeah.
Hey, so what's the pathophysics? The brief pathophysics here, Marlena. We don't like to get
Yes,
into the
brief.
Well, that's the PhD.
Brief.
Explain this.
No, we are asking the PhD.
Yeah, can you explain the science, please?
I'll do my best to use
Dumb it down for
short
us.
words. So, in bowel obstructions, you have dilation of bowel proximal to the obstruction, and that results in accumulation of intestinal secretions and partially digested stuff. The peristalsis is stimulated because of that, resulting in early loose bowel movements, nausea, vomiting. Then the bowel wall becomes like edematous and swollen, and you're going to have decreased absorption capacity, causing more dilation, decreased venous return, and ultimately decreased arterial flow. There's bacterial overgrowth and translocation into the bloodstream that can happen because of the stasis and increased bowel wall permeability that happens with all that edema. And then you get extensive fluid losses, recurrent vomiting. Then you can see a metabolic alkalosis, electrolyte abnormalities, hypovolemia, etc.
etc.
That's enough pathophys to last you like a year on this podcast.
Yeah.
That is. And really, a lot of these folks are going to be volume down, and just there's also this third spacing thing that happens in their gut. So just make sure they're getting plenty of fluids, and then also, metabolites can be very off as well. So that's really the key. There's like closed loop and different types of loop. Do we even need to get into like closed loop? Let's not get into that. Can we not? I mean, bowel obstruction is bowel obstruction.
It's worse.
Is that okay? Yeah.
It's bad. Scary stuff.
It's worse. Yeah,
Both ends are closed off.
Yeah,
It's basically a cul-de-sac.
And surgeries are more, surgical teams are going to be more interested in a closed loop, honestly. And it can lead to more complications. We're not going to get into other stuff. Let's get into the presentation, how these things present. Because I do think there are a couple key points here. The abdominal pain, the way it's described oftentimes can be sudden, but colicky in nature as well. This like crampy, sudden pain. So you'll have patients who are like, man, I was feeling fine. And then just started to ramp up very quickly. Usually your SBOs aren't like a day ramp up in pain. No. It happened pretty suddenly, relatively suddenly within the last few hours. You're going to have that abdominal distension oftentimes, but not always. And then the nausea vomiting is key. If they're not having nausea vomiting, the chance of it being like a bowel obstruction is like very low. But again, a lot of nausea vomiting. I don't know about you guys, but the whole like not passing gas, that's probably going to be asked on the boards. Hey, the patient isn't passing gas. That's not a bowel movement. But in real life, I find that to be so subjective. I'm like,
yeah.
You know what I mean? Like, have you guys seen that? I don't know. What is y'all's opinion on that?
Yeah, I agree.
And oftentimes they're still like having bowel movements too. But I do like asking them. I'm like, you farting?
I ask them too.
Yeah, exactly. Boom. Are you? And then they're like, I don't know, I guess maybe.
If they're not vomiting and they're passing gas, then obviously my suspicion goes way down. I know that there's no single historical feature that can rule in or rule out a bowel obstruction, but you're getting that sense, and you're talking to the patient in the room, and you just kind of feel it out. And if they're saying I'm passing gas, I'm having diarrhea, and I'm not vomiting, I'm like, okay, well, it's probably not going to be a bowel obstruction. I don't know.
Yeah.
It's like my thought of things, but you've definitely been surprised before. I think all of us have been surprised.
All of us.
You're like, bowel obstruction. But then again, I will say, sorry, I'll back up. Yeah. We've been surprised, but nothing ever bad happens to those people. Like if they're coming in that mild, then it's always going to be something like, oh, we're just going to watch them and do serial abdominal exams, which we'll get to in a minute.
Yeah, and again, these folks, I do think that presentation is like they'll be diaphoretic sometimes, kind of clutching their abdomen. It's like, oh, something's definitely going on,
right.
With this patient. And a couple other key things. Remember, in this patient, we presented prior abdominal surgery. We'll get into some of the adhesions and things here in a second, causes, and then a history of radiation treatments or therapies as well. So those are some important questions to ask prior abdominal surgeries. Ever had a history of cancer and sort of radiation therapy? therapy.
Right.
And again, on physical exam, man, get into
Here,
some.
let me
of
ask you a
those-
question. Let me ask you a question. When's
I know exactly.
When's the
I know
last
exactly
time-
what you're about to ask me. Did you take that stethoscope? All right.
did you listen to all 4 quadrants of the BAB?
I like
Of
the
belly?
movement Marlene is doing the all
The
fours.
quadrants.
Hey, get
I
into
love when that's in like people's pre-populated note text. Bowel sounds normal. I'm like, really?
really.
Did you
Have-
really?
Did you? But did you?
Have you heard about the quad spot?
What is the quad?
This is from an unnamed attending I learned from in my residency. It wasn't you. Don't worry. He will go nameless on this podcast.
Okay.
Who taught me the way he listens with the stethoscope is he puts it at the xiphoid process so he hears the lungs, the heart, and the belly.
No. You call it the quad?
The quad spot.
And the med student listening was just like, their jaw dropped. They were like, what?
We're gonna have to take this
That's
one
possible?
offline. Have a further discussion.
May have been one of my more favorite attendings I worked with. Besides you, of course.
That would have been my favorite.
Yeah, it was awesome. All right, hey, let's talk about the physical exam. So early findings are extremely nonspecific. We just said how nonspecific the historical features were. So the physical exam is going to be, generalized tenderness to palpation, whatever. It's not going to be focal ever. It's not going to be helpful. And I know we're joking around here, but on the test, they may mention you listening for bowel sounds.
They will.
And you're either not going to hear anything or you're going to hear this high-pitched, quote-unquote, tinkling noise.
Yeah.
But it doesn't matter.
WTF.
That's never going to be happening in real life. So just don't worry about it.
Yeah.
The late findings are when obviously a patient would easily declare themselves that you're going to scan them anyway. They come in with abdominal distension or pain. They have a fever or subjective chills, and they have peritoneal signs, rebound guarding, that kind of thing. Yeah. These are so obvious that you're going to scan them anyway, so it doesn't really matter to be on the lookout for these. These are the general not looking well abdominal pain patients who get imaged regardless. And so that's, I think, not that helpful. The more helpful thing, the more testable thing are going to be the causes here.
Always.
Now, yeah.
You got to know this.
Since med school, you've been tested on this.
Yeah, and you're going to see small bowel obstructions. It's on the clinical model for ABEM. They will ask you the
on your oral
causes
boards
for it.
too.
That's how you test on this, basically, right? So oral boards, and then also just in general board questions. You should knock these out of the park.
Right.
But this is how they're gonna
90%
try
of
to tag
obstructions are caused by these top 3 things.
it. Okay, 90.
In this order, too.
Are we doing a
Adhesions.
short? Are we doing a short?
do a
Okay,
short.
let's go.
No, Marlena should do it. Marlena should do it. Do the short.
Yeah, you're going to do the short. Okay.
Put the sparkle eyes on.
All right. Sparkle eyes. Boom.
All right.
Okay. Go. Hey, set her up. Set her up, Briggs.
Okay, go. What are the top 3 causes of bowel obstructions, both large and small?
Adhesions.
Done.
Hernias.
Done.
Neoplasms.
Done.
And the test question and answer, the number one cause of all bowel obstructions.
Adhesions.
Done.
Done.
And if they're asking about the number one cause of large bowel obstructions.
Tumors.
Tumor.
Boom. So all bowel obstructions is going to be adhesions. But if they're asking for large bowel obstructions, it's going to be
tumors.
Tumors.
Neoplasms. Masses.
Boom. Done. I love that short. What are some of the other causes of Molina?
Hernias, malrotations, volvulus, intussusceptions, endometriosis. It's a weird one. Crohn's disease and strictures, appendicitis, actually, ischemic bowel, which is why you want to get contrast on your CT, toxic megacolon, and then Hirschsprung's, usually in the little kids, although I recently had a 20-year-old with Hirschsprung's diagnosis.
Fascinating.
They
Interesting.
never poop their entire life.
Yeah, it kind of looked like that, honestly.
Oh my gosh.
That's kind of weird. Hey, so lab tests, as usual, not helpful. I can't wait till we have a podcast one day where we say, get this lab test and you'll get the diagnosis.
I know, right?
This is why we don't have a podcast on it. It's too easy.
I know.
So lab tests here, commonly ordered tests. White blood cell count, not helpful. Lactate, Everybody loves talking about lactates for
Especially
many things.
the surgeons want a lactate
my
every
gosh.
time. If you haven't
Yeah.
ordered it, they're going to ask for it.
that's
So
right.
is it going to be elevated in bowel ischemia? Sure, maybe. Is it going to be a late finding? Probably.
Yeah.
Does it really matter? No.
No,
Doesn't matter. It doesn't matter. So
you should get it. You should get labs. But
Sure,
we're just
whatever.
saying it's not. That's not the end all be all, right? So
Like, really just check your electrolytes, because those are the things that are going to be the most out of whack
Yep.
that you might want to fix.
exactly.
they prompt you to give Gatorade. That's what patients tell me all the time.
We're getting
I'm
into a
drinking
touchy.
Gatorade Zero.
Hey, we're getting into a touchy subject here. Okay, guys.
Gatorade?
This is no imaging.
Oh, okay.
Imaging,
Oh,
Yeah.
guys. This
I'm about
whole
to offend some
abdominal X-ray versus CT scan.
I didn't know there was a competition.
I'm not gonna get in. I'm not gonna get on my soapbox. You know what? This is a
in your
sensitive
soapbox.
topic. I'm gonna let you two handle this. I'm gonna
Okay.
let you two handle this, and I'm gonna try not to interrupt. You guys
Well,
do your thing.
What's bothering you about it besides that?
Just get into it. You know?
Okay.
I'm gonna
just
try to
that
keep my mouth
abdominal
shut.
x-rays exist.
Yeah.
Just
At all. That bothers me.
Just get into it. Just go.
So the only time you should get an abdominal X-ray is if you don't have CT, or if the patient can't go to CT. That's really it. But
Yeah.
nowadays, in the modern age, there's really no excuse not to get a CT to diagnose a small bowel obstruction.
Mm-hmm. Yeah. Abdominal x-rays, they don't have good sensitivity. They don't have good
No.
specificity. You should not rely on that for your diagnosis.
No.
If they present you with one on the test, the things that they may mention are that there are dilated loops with air fluid levels
Mhm.
and the string of beads sign, which are like small pockets of gas within a fluid-filled small bowel.
Yeah, I mean, my thing is it's going to be non-specific, and it's going to show you like all types of stuff. Sorry, I have to get in here. I know I told
we
you
go.
guys
held
I
back as
wouldn't.
long as he could.
I held
we
back
go.
as long as just hold me back. But I don't understand when folks say, "All right, let's get a plain film KUB," and I'm like, "Why? Like, what are we doing? Are you
People
worried
are
about a
asking for
small
that?
bowel obstruction, or are you not?" You know, I mean,
Huh.
people will kind of bring it up, right? Because they'll
Oh,
read
really?
like med students will like read the
Sure.
literature out there, and some of it will show, oh, KUB can show this string, and I'm like, if you're worried about it, you need to be getting a CT scan.
Of course.
Like,
Yeah.
I don't think I've ordered like a plain film abdominal, other than like to look for foreign bodies and other things like that, to for this in like 10 plus years. I just haven't.
Yeah. No, I agree.
That's not something that you do. If you're worried about a small bowel obstruction, what you're going to be doing is getting a CT scan. The only time here that I can potentially see where you get a plain film KUB is that patient who's had multiple small bowel obstructions. They know exactly what their symptoms are like, and then you get the plain film to take a look because they've had so many CT scans done. But other than in those kind of very niche cases, I'm not getting a plain film of the abdomen. It's crazy.
Right.
It's ridiculous that we even have to have this discussion in 2024.
Mm-hmm.
Right.
I'm so sorry. I'm gonna leave.
You feel better? Got it off your chest?
Sometimes it's good to get that out.
Yeah.
Hey, let's talk about CT scan. It's the most accurate, readily available test in the ED. And it's pretty quick to get.
Yep.
It's actually funny. I had a patient the other day, old fought, that was very similar, and the resident did suggest an abdominal x-ray for unrelated reasons. No, not for a small bowel obstruction. And I said, we can go to CT. And they're like, well, they're not very stable. I'm like, well, CT scans taught in med school act like you go down, out of town for a while and come back. That's
Right.
how long it takes. But in modern medicine, CT scans take like 30 seconds,
Right.
if you can get there.
Yeah.
So in reality, the paradigm is shifted of, unstable patients still can go to CT,
Right.
for the most part. Anyway, much to the cries of CT techs everywhere. Anyway, dilated loops of bowel are going to be seen on a CT scan. And typically they're going to measure greater than 2 centimeters if you measure the outer wall of the bowel. And you're going to see collapse. Loops of bowel distal to the obstruction, of course, are decompressed. And then you're going to see, potentially, if it's a late finding, intestinal ischemia.
Hey, do a short on this and repeat it. This is important because on even your written exam, they might actually show you images of this. And
They could.
They will expect you to be able to diagnose a small bowel obstruction without a radiologist. It is a diagnosis that you should be able to knock out the park on CT imaging yourself. They're not going to be expecting you to diagnose ischemic gut and things like that, but a small bowel obstruction all day, every day. This is bread and butter EM stuff. So let's start with the short. What are the CT scan findings that you might be presented with on a test or oral boards when they show you certain images of this?
Yeah, so the obvious findings you're going to see are dilated loops of bowel greater than 2 centimeters. You could also see collapsed loops distal to the obstruction, so you're not going to really see that much swelling in that bowel area. And then any signs concerning for ischemia. So like a thick bowel wall, we talked about already. It could be portal venous gas, which is not something you're going to be actively looking for, but you could also see air in the bowel wall, and that's pneumatosis intestinalis. That's not specific, but in an adult patient, if you see that, that's extremely concerning for late stage bowel, ischemia infarction.
Great. And in general, we would recommend you guys looking at images as well online for this, because you need to know it for honestly real life, and also just for the test is great.
Yeah.
Hey, what's the other great thing that CT scans can do, guys, other than diagnose a small bowel obstruction?
Tell you what the cause is.
Yeah, why?
Yeah, a lot of other stuff.
Yeah.
Hey, what's something that a KUB is not going to help you with?
A lot of things.
Anything else.
Other stuff. Yeah. Great. Thank you.
Speaking of another controversial area.
Ooh, abdominal ultrasound.
Abdominal ultrasound. This gained so much traction like less than 5 years ago.
Yeah.
And I never understood why. I'm sorry to people that love ultrasound listening to this, but I love ultrasound, but I just don't see this ever panning out anytime soon. Imagine getting an ultrasound and then calling your surgeon and saying, "Hey, I got a small bowel obstruction." And they're like, "Oh, what the CT show?" Like, "Don't worry, I got an ultrasound."
It's like,
Yeah.
I got you.
I got you. I saved us plenty of time. So consulting services aren't going to accept this. I don't completely disagree with them not accepting this. I mean, the CT provides so much important information.
Yeah.
Like the cause of the obstruction, the entire mapping of the bowel, and looking for ischemia, infarction, et cetera. And so I'm not throwing shade on this whole ultrasound development here, but I don't see this actively being a replacement for CT anytime soon or ever.
Yeah.
So that's just my opinion on it. That's my soapbox.
Love it.
Thankfully, I never see it ordered, so it doesn't really matter. So
I want you to know that you're heard. You're heard.
Great. Hey, let's talk about management complications and get out of here before my voice fails.
Yeah.
Yeah. Patients with the closed loop obstructions that we talked about earlier that are worse can become septic and obtunded. They'll keep vomiting, and if it's really bad, they can go into shock. So those are the scary ones. But most cases just need some hydration because of that intravascular volume depletion and third spacing. So you want to give them some isotonic fluids, fix their electrolytes as needed. And then antiemetics, obviously, they can be helpful in the people with partial small bowel obstructions if they're not actively vomiting. You're going to give them an antiemetic regardless.
Yep. And then, surgical consultation is going to be important. I know this can be kind of controversial at different shops. Some folks will be managed on the medicine team, some folks on the surgical teams, but certainly surgery on the test and on oral boards, it's going to be surgical consultation for this all day, every day. Oftentimes these patients are going to recover with serial abdominal exams. And again, you're not, giving them food and all this other stuff, right? You're just, they're going to be NPO initially at least. And then we're not going to really get into why surgery would take this patient to the OR or anything like that. That's really up to them.
Very subjective.
Yeah, it's very subjective. It just depends. So at the end of the day, the answer is going to be surgical consultation for these patients. Obviously, look, there's like an elephant in the room here. So, and that elephant in the room is the NG tube. That's kind of that's there. So I'm going to let Marlena get into that. Marlena and Briggs, you guys handle this one.
Yeah. So traditionally, these patients all got NG tubes, but the literature doesn't really defend that, which we're definitely not going to go into any kind of deep dive in, but just know that it's not super supported by literature. And if a patient isn't vomiting anymore, if you gave them some Zofran and they're not nauseous or vomiting anymore, why are you going to put an NG tube in? They will hate you afterwards. Yeah.
There's actually studies that show that NG tube placement is actually one of the worst patient experiences in procedures that's done for a patient.
Followed by chest tube.
Yeah, patients actually rank it higher or worse than the whole intubation process.
That's crazy.
But again, if the patient's very symptomatic, actively vomiting, sure, putting an NG tube can certainly help. You can get a ton of fluid out. that might be causing a lot of that discomfort. But just also understand, it's not, you delaying the NG tube is not going to all of a sudden, oh my gosh, you didn't put an NG tube in the moment that patient like sat down in the ED bed. It's nothing like that.
Yeah.
Yeah.
I will say if they're in septic shock and getting altered and you're going down that route, you may want to put down an NG tube because you don't want to end up in the place where you have to intubate them due to like poor mental status and their stomach is full of bile.
Yeah.
That's going to be a bad situation
That's terrible. Yeah, you do not want aspiration to be happening there. That's what we would call suboptimal.
Suboptimal.
Suboptimal. Well, that's it for us. I mean, I
It's
feel
been
like
an absolute pleasure.
Yeah, it's been an absolute pleasure to have like the trio, the team here assembled for all of our folks listening and viewing pleasures. Marlene and I are both quite disappointed, Blake, that your voice came back because we had jokes ready to go.
Yeah, I wanted the chipmunk.
Everything.
I willed it to come back. I was like, I need this back for the podcast.
Marlena had memes ready to go, lined up on Twitter. And we were, I'm sure, our social team as well. Alexandria was just ready to go crazy on this, but
I had a show that I was stronger than Ultifat since he was sick on the last podcast.
Yeah. I actually had fevers and a real illness, not an illness secondary to walking outside in the cold. Okay.
Oh, very clever.
All right. So just FYI, just saying.
Gotta get my steps in.
I know. Anyways,
steps in.
Any funny stories, guys? Since we have all of us assembled, anything?
No.
Any interesting presentations of late?
No, I'm on a radiology elective, so
That's very
How's that going?
Calming.
that's lovely. It's so dark and quiet.
Are you getting something good out of it? Like any interesting imaging things? Any pro tips for any of us out there?
I'm mostly doing like neurorad stuff, so things that hopefully you won't ever have to look at on your own.
Are they telling you, hey, we just really appreciate it when you guys list out in detail what the symptoms are? How many times have they told you guys?
Oh my God.
They probably told you that's the first thing. They're like, can you just tell your colleagues that saying weakness doesn't help us? We would prefer
Pain.
5 paragraphs.
Right.
Sepsis.
I do see where they're coming. Sometimes I'll be
hurts everywhere.
Sometimes I'll be ridiculously specific, where I will like put exactly my differential like spelled out.
I do the
like,
same thing.
I hope this helps, but in seriousness, saying things just like weakness is not going to be helpful.
No, it's really not.
Colleague,
Give them anything else is more helpful. I like throwing in like interesting patient details in there sometimes. Like one time I had an x-ray of a guy's toe and an indication I was like running from bees, stubbed toe. And the radiologist literally called me and was like, what's the rest of the story? Why is this man being chased by bees?
Very clever.
I love it. That was great. Yeah, I need to start doing that. I need to start doing that. In mentioning like what is going on.
Just like brighten up their day a little bit.
Yeah,
they don't get to hear any of these ridiculous stories.
Not that bright. They're gonna melt. Careful.
They're gonna melt.
Has to be dark for them. Be careful.
Oh man, good stuff. Well, that's a wrap. It was good to see you guys. And this is on the YouTubes. Check out the YouTube channel. Support us. Subscribe.
YouTube.
Can you like a YouTube channel? Is that how it works?
Where have you been?
Great.
Like, subscribe.
I don't know. I know you can subscribe. Everyone says like hit. Hey, Marlena, is this what you do? Hit the subscribe button.
I don't know. Where we're going to be spaced on the screen. You could be like,
I'm going to do, subscribe. I'm going to do multiple things so Alexandria can insert. So subscribe to our channel. Knowing her, she's going to turn this into like a separate short. But anyways, and apparently we're on TikTok too, and we're doing good on TikTok, guys.
Oh, nice.
Right? That's pretty awesome. And then
everybody's sick of the dances.
Everyone's saying, there you go. I know, right? And then on the Twitter, thanks for rocking out on that, and Marlena. When are we going to hit 20,000? We're going to hit 20,000 followers soon.
Pretty soon, I bet.
Right?
I thought we did.
Before the end of the year. Well, where are we right now with that?
Let's see. We have 13.2 thousand followers.
Boom. Let's go. So Yim Rapid Bombs, board studying's coming up, ITE stuff, and just general EM content. We appreciate you guys supporting us. Multiple podcasts dropped a week. You can find EM Rapid Bombs by going to our website, emboardbombs.com, clicking on the interactive question bank that we have. And that's it. Appreciate you guys.
See you next time.
Bye.
Bye.